If you watched last week's video, you know the Medicare Physician Fee Schedule, or PFS, has been released. Well, did you know there are new codes for e-visits, guidance on physician assistant supervision, and evaluation and management services? If not, this video will provide you with all the information you need. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And on this channel, we provide you with information, tips, and strategies on how to become a certified marketable medical coder. The Medicare Physician Fee Schedule for calendar year 2020 was released on November 1st. And if you are involved with coding physician services, there are some nuggets for you. In this video, I will focus on guidance related to e-visits, physician assistant supervision, and evaluation and management. First up, online digital evaluation services or e-visits. There are two sets of e-visit codes in CPT. You have CPT codes 99421 through 99423, and they are for practitioners who can independently bill E&M services, and CPT codes 98970 through 98972, which are for practitioners who cannot independently bill E&M services. For background purposes, the statutory requirements that govern the Medicare benefits are specific regarding which practitioners may bill for E&M services. As such, when codes are established that describe E&M services that fall outside of the Medicare benefit category of the practitioners who may bill for that service, CMS has typically created parallel HCPCS codes, G codes, if you will, with descriptors that refer to the performance of an assessment rather than an evaluation. They acknowledge that there are qualified non-physician healthcare professionals who will likely perform these services. So for calendar year 2020, CMS has proposed and finalized separate payments for online digital assessments, or e-visits, via 3 HCPCS G codes that mirror the CPT codes 98970 through 98972. The HCPCS G codes and descriptors are as follows. HCPCS code G2061 is for a qualified non-physician healthcare professional online assessment and management for an established patient for up to 7 days. Cumulative time during the 7 days for 5 to 10 minutes. HCPCS code G2062 is for a qualified non-physician healthcare professional online assessment and management service for an established patient for up to 7 days, cumulative time during the 7 days, 11 to 20 minutes. And then you have HCPCS code G2063, qualified non-physician healthcare professional assessment and management service for an established patient for up to 7 days, cumulative time during the 7 days, 21 or more minutes. There are many practitioners for whom these services fall outside the scope of their benefit category and, as such, may not receive separate payment for these services under Medicare. Next up, we have physician supervision for physician assistant services, or PAs. In 1986, a long time ago, CMS added a section to the Act to establish a benefit for services furnished by a physician assistant under the supervision of a physician. The regulation required PA services to be furnished under the general supervision of a physician. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And on this channel, we provide you with information, tips, and strategies on how to become a certified marketable medical coder. This general supervision requirement was based upon another long-standing regulation that defines 3 levels of supervision for diagnostic tests, which are general, direct, and personal supervision. Of these 3 supervision levels, general supervision is the most lenient. Specifically, the general supervision requirement means that PA services must be furnished under a physician's overall direction and control, but the physician's presence is not required during the performance of the PA's services. In 2018, CMS solicited a request for information because there were changes in the practice of medicine for PAs. And as a result, CMS is finalizing PA physician supervision, and it is as follows. A PA must furnish their professional services in accordance with state law and state scope of practice rules for PAs in the state in which the PA's professional services are furnished. Any state laws or state scope of practice rules that describe the required practice relationship between physicians and PAs, including explicit supervisory or collaborative practice requirements, describe a form of supervision. For states with no explicit state law or scope of practice rules regarding physician supervision of PA services, physician supervision is a process in which a PA has a working relationship with one or more physicians to supervise the delivery of their healthcare services. Such physician supervision is evidenced by documenting at the practice level the PA's scope of practice and the working relationships the PA has with the supervising physicians when furnishing professional services. Next, let's talk about the guidance on the review and verification of medical record documentation. In an effort to reduce mandatory and duplicative medical record evaluation and management documentation requirements, in the calendar year 2019 PFS final rule, it required as a condition of payment under the PFS that the teaching physician must be present during certain portions of services that are furnished with the involvement of residents. Residents are individuals who are training in a graduate medical education program. Now, there are a few exceptions, and we won't go into all of the exceptions in this particular video, but just know that they exist. Guidance requires that the teaching physician's presence and participation in services involving residents must be documented in the medical record. CMS has amended the regs to provide that a physician, resident, or nurse may document in the patient's medical record that the teaching physician's presence and participation requirements were met. As a result, for E&M visits furnished beginning January 1st, 2019, the extent of the teaching physician's participation in services involving residents may be demonstrated by notes in the medical records made by a physician, resident, or nurse. Well, in February 2nd, 2018, a paragraph in CMS's manual instructions on teaching physician services in the Medicare Claims Processing Manual was revised to reduce duplicative documentation requirements by allowing a teaching physician to review and verify, that means sign and date, notes made by a student in a patient's medical record for E&M services, rather than having to redocument the information, largely duplicating the student's notes. This was all probably related to cutting and pasting. A correction was made and regs were reissued on May 31st, 2018 that contained a list of definitions that were pertinent to teaching physician services. So following these amendments to CMS's regulations and manual, certain stakeholders raised some concerns. So CMS proposed to establish a general principle to allow the physician, the PA, or the APRN who furnishes and bills for their professional services to review and verify rather than redocument information included in the medical record by physicians, residents, nurses, students, or other members of the medical team. They explained that this principle would apply across the spectrum of all Medicare-covered services paid under the PFS. CMS noted that because the proposal is intended to apply broadly, they proposed to amend the regs for teaching physicians, PAs, and APRNs to add this new flexibility for medical record documentation requirements for professional services furnished by physicians, PAs, and APRNs in all settings, specifically to reflect a simplified and standardized approach to medical record documentation for all professional services furnished by physicians, PAs, and APRNs paid under the PFS. They are proposing to amend a new paragraph to the regs entitled Medical Record Documentation. And that paragraph specifies that when furnishing their professional services, the clinician may review and verify, again, sign and date, notes in a patient's medical record made by other physicians, residents, nurses, students, or other members of the medical team, including notes documenting the practitioner's presence and participation in the services, rather than fully redocumenting the information. CMS also noted that while the proposed change addresses who may document services in the medical record, subject to review and verification by the furnishing and billing clinician, it would not modify the scope of or standards for the documentation that is needed in the medical record to demonstrate medical necessity of the services or otherwise for purposes of appropriate medical record keeping. Other amendments include allowing physicians, residents, nurses, students, or other members of the medical team to enter information in the medical record that can be reviewed and verified by a teaching physician without the need for redocumentation. For calendar year 2020 PFS final rule, CMS is naming PA and MP, CNS, CNM, and CRNA students as APRN students, along with medical students as the types of students who may document notes in a patient's medical record that may be reviewed and verified rather than redocumented by the billing professional. And also adding a new paragraph under the definition of CRNA to include CRNAs as a category of APRNs for purposes of this policy, and to include CRNA students under the reference to APRN students. And lastly, as it relates to payment for evaluation and management visit, or E&M visits as we affectionately love to call them, CMS will adopt the following policies for office and outpatient E&M visits effective January 1st, 2021. First, separate payment for the 5 levels of office and outpatient E&M visit codes as revised by the CPT editorial panel effective January 1st, 2021. This would include deletion of CPT code 99201, which is the level 1 code, and adoption of the revised CPT code descriptors for CPT codes 99202 through 99215. Next, elimination of the use of history and or physical exam to select among code levels. 3, choice of time or medical decision making to decide the level of office or outpatient E&M visit using the revised CPT interpretive guidelines for medical decision making. 4, payment for prolonged office and outpatient E&M visits using a new CPT code, deleting HCPCS code GPR01 that they previously finalized for 2021 and no longer recognizing CPT codes 99358 through 59 for separate payment in association with office and outpatient E&M visits. And then revise the descriptor for HCPCS code GPC1X as visit complexity inherent to evaluation and management associated with medical care services that serve as the continuing focal point for all needed healthcare services and or with medical care services that are part of ongoing care related to a patient's single, serious, or complex chronic condition. This is an add-on code, so you would list this separately in addition to an office or outpatient evaluation and management visit, new or established code. And then they will also delete HCPCS code GCG0X. And lastly, increase in value for HCPCS code GCG1X and allow it to be reported with all levels of outpatient and office E&M codes. Now, we will be enjoying the holiday season and we will not have a video released next week. But are you planning to sit for the CPC exam in the coming year? Well, next year I will begin a series on the top missed coding concepts on the CPC exam. You don't want to miss it. Also, if you have areas that you would like to see reviewed, let me know in the comments and I got you. We will also give you a sneak peek at that 2021 table of or medical decision making for evaluation and management services, including the table of risk. I'm Clarice Warner, the girl with the pearls, the founder and education director of the Professional Reimbursement Reimbursement Network, LLC, where coding education is key, providing you with information, tips, and strategies on how to become a certified, marketable medical coder. If you are interested in more information on these tips and others on how to become a certified, marketable medical coder, well then check out these videos and check this out.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified, marketable medical coder. Learn more at bit.ly/5stepscoder.
Feel free to subscribe to our channel and don't forget to click that bell for notifications when we upload new content. Also, I love hearing from you, so let me know you were here by providing a comment. I read all the comments and I do respond back. So let's stay connected and connect others as well. Remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care, Merry Christmas, Happy Kwanzaa, Happy New Year, and thanks for watching.